welcome back to the next chapter of Community Paramedic. So we are going to now take a jump into patient assessments. This is the longest PowerPoint, I think, of all of the material that you guys have. So we'll do my best to get it in under 30, but doubtful. There's a lot of information in this PowerPoint because this is definitely needs to be one of the prime focuses that you have. In 911, assessments are about speed and the immediate stabilization. In community paramedic, it's a little bit different. It's slower, deeper, and often about preventative. So definitely have to change the way that you assess your patients moving forward with this program. So the environment is usually the patient's home, not the back of the ambulance. So goals shift towards long-term management, not just that emergency response. Patient assessment is the foundation of everything that we do in all cases. In emergencies, the focus is what do I need to fix right now? For your CCPs, the question becomes what do I need to uncover now to prevent future emergencies? Every regimen, care plan, and outcome ties back to this step. Assessments have both subjective data, that's what the patient or the family tells you, and objective data, that's what you find. So in 911, you may not have time to dig out deep into subjective reports. As a CCP, you often can, and you should, spend that extra time exploring what the patient believes and experiences. Objective findings back up what patients do say. In the streets, we may rely heavy on the physical signs. As CCPs, we use objective data to either confirm or challenge what patient reports, especially since chronic conditions may have some confusing or overlapping symptoms. Symptoms equal what they feel, signs equal what you see. For us as community paramedics, we need to connect both for the complete ongoing picture of your patient. Goals of patient assessments, supplemental PCPs, reaffirm PCP findings, and provide ongoing monitoring and management. There are different roles in 911 versus CCP. So in 911, our goal is short term. We find life threats, we stabilize, we get the patient to more definitive care. We're not there to follow up or monitor. The hospital takes over. That's their job. As a CCP, your role is long term. You're helping the patient stay out of the ER by supporting what their primary care physician has already established. Supplementing primary care, you're not replacing the physician, but adding an extra set of trained eyes between visits. Think of it as a safety net. You might catch medication mismanagement, worsening chronic conditions, or social factors that the primary care provider does not see. We're also reaffirming the physician's findings. Sometimes patients leave a doctor's office and don't fully understand the instructions or all those fancy medical terms that they left with their head full of. As a CCP, you can reinforce education, showing them how to use inhalers properly, reminding them about diet changes, or helping them manage new medications. Ongoing monitoring and management is also part of it. Unlike 911, where you may only see the patient once, as a CCP, we're often involved those repeated visits. This lets you track trends. Is their blood pressure creeping up? Is their weight increasing in a CHF patient? You can escalate changes early and preventing crises that would otherwise lead to 911 calls. So why this matters? The goal shifts is one of the biggest differences between 911 and CCP assessments. And not critical care, in a community paramedic, you're less focused on what will kill this patient in the next 10 minutes and more focused on what might put them in a crisis in the next 10 days or the next 10 months. That perspective requires patience, thoroughness, and a strong communication skill set. Community paramedicine assessments are not bound by the same time crunch. You can perform broader, more detailed exams. Think of it like detective work, putting puzzle pieces together before that crisis even develops. There are elements of assessments. There's general info, chief complaint, the history of patient illness, past and family history. In 911, this often gets abbreviated or skipped under pressure. As a CCP, you get to gather the full picture, including generational and environmental factors as well. Our social history, medications, allergies, vitals, and a review of the systems. Our CCP assessments go deeper into social history and lifestyle factors, which often drives health outcomes more than a single acute event. Be prepared, be professional, and set the right environment. In the streets, the environment is uncontrolled. We adapt. As CCPs, we can control it, mostly. There's generally a quiet space, we have comfort, and there's trust building that occurs. When we move into patient assessments in the community setting, communication becomes just as important as the exam itself. I want to make sure the patient knows what to expect at every step. In the 911 world, we don't always have time to explain. We're rushing to stabilize. But in community paramedicine, slowing down and setting expectations makes patients more comfortable and often gets better information. Start by gathering demographic details and then ask about their chief complaint, their history of present illness, past medical history. We should all be very familiar with that flow. This structure helps keep everything organized and reassures the patients that you are being thorough. After the initial history, move on to the physical exam, but don't stop there. Gather data from devices like glucometers, the home blood pressure cuffs, CPAP machines, or even lab values if they're available. This is a major difference here. In emergency, we rarely have time to dig into a patient's home health devices. As a CCP, those devices are gold mines of trending data. So wrap up the assessments by discussing recommendations or actions or interventions. Sometimes that's education, sometimes it's coordinating with their doctor, and sometimes it's catching a problem early before it becomes that 911 call. One of the big strengths of community paramedicine is how much more information we have to access. Beyond just our assessments, we can integrate electronic health records, home medical devices, point-of-care testing. That means we're not just looking at a snapshot. We're layering our findings on top of their medical history. In 911, you almost never have the luxury of a complete record, but in CCP, the EHR can tell you what medications they've been prescribed. Lab tests can confirm or rule things out, and device data can fill in the gaps between doctor visits. This creates a more complete picture of the patient's overall health. Another big advantage is continuity. In 911, you see the patient once and you may never see them again. In CCP, you often see the patients regularly, and that allows you to track trends. You can measure things like lung function, peak flows, or even weight gain in CHF patients once again. This trending is powerful because you're spotting issues before they explode into emergencies. You're not just reacting, you're predicting and preventing. When it comes to interviewing patients, professionalism and empathy set the tone. In 911, you may not have time to build rapport. You're asking rapid-fire questions while starting interventions. In community care, the pace is different. You want to be collaborative, supportive, and above all, respectful. Patients often feel vulnerable, so maintaining confidentiality and privacy builds trust. And it's just as important, use this as an opportunity to promote positive health behaviors. If we model respect and non-judgment, patients are far more likely to open up and share the details that really matter to them. Body language is powerful in patient interviews as well. Tilting your head, leaning slightly forward and engaging, maintaining eye contact, that shows you're listening. They're small actions, but they make patients feel comfortable and respected. When you're relaxed and engaged, they're much more likely to share the details that matter to them. There are also habits we want to avoid. Standing over a seated patient can feel intimidating. Crossing your arms or failing to look up from your notes sends the wrong signal. The goal is to create a safe space where the patient feels like their story is the most important thing happening in that moment. Start your interview with those open-ended questions. A simple, "Tell me what's been going on with your health lately," can open the door to information you wouldn't have uncovered otherwise. Patients often reveal details about their routines, challenges, and concerns when they don't feel boxed in by yes or no questions. The closed-ended questions are useful when you need to narrow down details or confirm information. For example, you might ask, "Did you take your medication once or twice a day?" These questions help keep the conversations focused and prevent long, wondering answers when specifics are important and needed. So not every patient interview is going to go smoothly, just like none of our calls always go perfectly. Some patients may stay silent, others may talk endlessly, and a few may become frustrated or even hostile. The key is adjusting your approach. Gentle prompts can help the quiet ones. Firm redirection keeps things on track with talkative patients, and patience and calmness can de-escalate those who are upset. Language barriers, hearing loss, or vision problems can also make assessments difficult. These challenges take extra time and creativity. Maybe you need a translator, maybe some written notes, or an adaptive communication tool. The important part is to not let these barriers stop you from getting the information that you need. Every assignment begins with the basics: name, date of birth, and other IDs. It might feel routine, but accuracy here is essential. Verifying details against medical records helps prevent errors and ensures continuity of care. The chief complaint is whatever the patient says is the reason they need help. Capture it in their own words, even if it doesn't sound medical. Quoting the patient directly not only preserves their perspective, but can also highlight patterns over time. And with this, the history is where we use our OPQRST and then introducing ASPN, if you haven't heard that before. That's the framework to help break down the complaints. When did it start? What makes it better or worse? What does it feel like now? How severe is it? Asking these structured questions helps uncover details that might otherwise be missed. So the OPQRST is onset, provocation and palpation, quality, region, radiation, severity, time, and then we have associated symptoms and pertinent negatives as well. Our past medical history often explains the present problem. Take time to ask about childhood illnesses, surgeries, pregnancies, or mental health conditions. A thorough past history gives context to the patient's current situation and helps guide those next steps as well. Our family history reveals inherited risk. Ask about parents, grandparents, siblings, and children. Conditions like diabetes, heart disease, or cancers often run in families, and knowing this helps you anticipate possible complications down the line. Social history tells you about the patient's life outside of medicine. Do they have that family support? Do they live alone? Are they active in social groups, or are they isolated? These details explain a lot about how well a patient can manage their health and follow treatment plans. Medication review is one of the most important parts of the assessment. Document everything, the prescriptions, over-the-counter drugs, those supplements, or even home remedies, that apple cider vinegar they take daily. So don't just let them sit or list them. Check on how the patient is actually taking them. This step prevents errors, reveals problems before they turn into emergencies. After the history comes the physical exam. This is where you use the systemic approach, moving from one body system to the next. Take your time, explain each step, and always protect the patient's privacy. A calm, organized exam builds trust and uncovers issues that patients may not even realize are there. The history should always guide the physical exam. If a patient describes chest tightness, focus more closely on the heart and the lungs. If they mention chronic stomach pain, spend a little bit of extra time on the abdomen area. Let their story direct where you look more deeply while still uncovering the basics. A good physical exam starts with the environment. Make sure the space is private, warm, and well lit. Patients are more comfortable opening up and cooperating when they feel safe and relaxed. Setting the stage is half the battle. Your equipment also does matter. At the very least, you're going to need a stethoscope, reliable timepiece, gloves, and a reflex hammer comes strongly recommended. Having the right tools at hand shows professionalism and allows you to complete exams without interruptions. Other essential tools would be, of course, blood pressure cuffs of many different sizes, a tape measure, thermometer. These simple tools are going to allow you to collect objective data that supports your history taking. So depending on your system and the objectives of your community, so you may be required to obtain patient weights with a reliable calibrated scale. Make sure it is calibrated. In eye examinations, pen lights can be used to find pupillary responses to light, and a gross assessment of anterior chamber depth. Additional visual assessments may include visual acuity using an assessment card. Oral examination may necessitate the use of a disposable wooden or plastic tongue blade, and a comprehensive neurological examination may include a sensory assessment of touch discrimination using 2 safety pins or paper clips for 2-point discrimination in a cotton swab. We have our all-favorite 12-lead EKG, our pulse ox, CAPNO. These can take a little bit of a deeper look into what's going on. We know they're not always needed with those routine visits, but when you use them consistently, you can trend changes over time. Rapport is the lubricant of the exam. It sets expectations, protects privacy, and allows you to move methodically. When patients trust the process, the exam yields better information. The exam isn't just for confirming the history. It often reveals what wasn't said. Combining subjective and objective data gives the most accurate assessment. Now, when we talk about the physical exam, 4 core techniques are going to guide us: inspection, palpation, percussion, and auscultation. Think of it as a progression. First you look, then you feel, then you tap, then you finally listen. Each step builds on the last. Skipping or rushing through these techniques means you may miss subtle but important findings. For example, noticing a slight facial droop on inspection could point you towards a neurological issue long before the patient even mentions symptoms. Inspection is simply using your eyes, but it requires a trained eye. You're looking at the whole person, their skin, posture, symmetry, scars, swelling, or anything that's unusual. The more carefully you observe, the better your next steps are going to be. Sometimes inspection alone tells you a great deal, like spotting jaundice in the skin or noticing unusual breathing patterns without even touching the patient. Inspection also means paying attention to the small subtle cues. So watch your facial expressions. Do they grimace when they move? Note their body movements and mood, and even how they interact with you. A restless patient may be anxious or in pain, while a flat or withdrawn affect can hint at depression or chronic illness. These quiet observations often guide the direction of the rest of the exam. Palpation uses your sense of touch to confirm or expand on what you saw. Light palpation helps you check surface tissues like skin texture or muscle tone, while the deep palpation allows you to assess organs or masses. Always explain what you're about to do, move slowly, and keep an eye on the patient's face. Their reaction can tell you as much as what you're feeling with your hands. Percussion may seem like an old school skill, and it's not very relevant in the back of the truck when things are noisy, but it is very powerful for CCPs. By tapping the body, you create a sound that reflects what's beneath. A hollow drum-like tone may suggest air, while a dull sound could mean fluid or solid mass. This technique helps you distinguish normal from abnormal without advanced equipment. It does take practice to master this, but once you develop an ear for it, percussion can become a quick and reliable tool. There are two main forms. We have direct percussion, where you strike the body surface directly, and indirect percussion, where you use one finger or another material to soften the blow. Indirect percussion is more common because it's less uncomfortable for the patient, but both methods do give you valuable information about tissue density as well as what lies beneath. Auscultation is listening to the body's internal sounds, most often with our stethoscope. Here, location does matter. You're going to hear different information depending on whether you're over the lungs, the heart, or the abdomen. What you're listening for also depends on what you suspect. Wheezes, murmurs, bowel sounds, or absence of sound altogether. Good auscultation means being symmetric, moving in organized patterns, listening carefully, and comparing both sides of the body. Those little differences can mean a lot. The order of the physical exam can be adapted to the patient, but a standard sequence keeps you consistent. So start with a general assessment, just taking in the patient as a whole. Then move into vital signs and finish with a more detailed review of the systems. This flow makes sure that nothing gets missed while still allowing flexibility to focus on areas of concern. Remember, you don't always have to do every step in the same order, but you should always be systemic. Some patients may need you to jump right into a focused area like the chest or the abdomen, but once you stabilize or address immediate needs, we're going to circle back to cover the basics. The physical examination isn't just a checklist. It is a structured conversation between what the patient told you and what their body is showing you. The general assessment is that first impression you get just by looking at your patient. You're asking yourself, do they look sick? Do they look well? Are there obvious signs of disease, disability, or poor health? It is a quick snapshot that sets the stage for everything else. When you dig deeper into general appearance, notice behavior, alertness, facial expressions, and overall demeanor. Watch how they move, the way they sit or they lie, whether they look comfortable or if they look to be in distress. Compare what you see with what the patient is saying. If they tell you they feel fine but they look like death eating a cookie, they're pale and weak, that mismatch is a red flag. Vital signs are essential for every visit, no matter how routine it feels. We know the good old pulse, blood pressure, respiratory rate, and temperature are the basics. We also want to do a pulse oximetry, weight, and height for a fuller picture. These numbers may not tell you everything, but they provide the foundation for spotting trends over time. When checking the pulse, don't just count beats. Pay attention to the rate, the rhythm, and the quality. A strong regular pulse is going to tell a different story than a weak irregular one. Taking the time to really assess the pulse gives you clues about circulation and overall cardiac health. Respiration deserves the same attention, so don't just guess on the respiratory rate. Look at the rate, the rhythm, and is it equal? Are the breaths shallow, deep, labored, or are they effortless? And try to observe without the patient knowing you're counting. People change their breathing if they know they're being watched. A full minute is always best for the most accuracy. Our blood pressure tells us a lot about our cardiovascular health, but only if it is measured correctly. That's why it is key to make sure you have several size blood pressure cuffs. We know our too small or too big is going to give us false numbers. So make sure that you are taking your time. We want to be accurate so we can track those trends. Don't overlook the temperature. Always note also how the temperature was taken, whether it was oral, rectally, tympanic, or temporal. Each area can produce a different reading. The body temperature does naturally vary throughout the day and can be influenced by recent activities as well. For some patients, especially those with chronic illness, even a small change in temperature can signal a brewing infection. There are different ways that we do our temperatures. Our rectal is the most reliable core measurement, but it's not really practical in most settings. So your tympanic and temporal scans are quick, comfortable, and useful for trendings, but are less precise. The key, though, is just making sure that you are using the same type every time you are recording a temperature. Our pulse ox, we know what it does. It looks at our oxygen saturation. We also know that it can be affected by cold fingers, nail polish, poor circulation, or it could give us false measurements. So make sure we're looking at our patient, not just the pulse ox. Once our vital signs are complete, move to a review of body system. The systemic approach ensures nothing gets overlooked. You'll cover the skin, head, neck, thorax, neurological system, GI system, musculoskeletal system. Each area does deserve attention, but you can focus more heavily on systems related to the patient's main complaint or their chronic conditions. The order of system review matters because it keeps your exam structured and efficient. So start with the skin, then move on to the head, the eyes, ears, nose, and throat. From there, focus on the thorax, both the cardiac and respiratory. After that, shift to the neurological system, then the abdomen for GI assessment, and finish with the musculoskeletal system. This flow makes it less likely that you're going to skip something, and it builds a logical picture from the outside in. Our skin is often called the window to overall health. When assessing, we're looking at the color, moisture, temperature, and turgor. Is the patient pale, flushed, jaundiced, or cyanotic? Is the skin dry or clammy? Temperature differences between body areas can point to circulation problems. Turgor, or how the skin snaps back after being pinched, tells you more about hydration. So turgor is one of the most practical bedside tools we have. Pinch the skin on the back of the hand or just in front of the ear. In a well-hydrated patient, the skin quickly returns to normal. In dehydrated patients, the skin may remain tinted or return slowly. While it's not perfect, especially in our older patients whose skin has lost their elasticity, it still gives valuable information when combined with the rest of the exam. So beyond our color and turgor, take time to look for lesions or abnormalities. Our rashes, purpura, vesicles can be signs of underlying diseases, infections, or medication reactions. Even small skin findings may be the first visible sign of systemic illness. Always document what you see clearly as well as accurately. Patterns of rashes and lesions matter too. For example, a butterfly-shaped rash across the face can be a hallmark of lupus. Our linear streaks might suggest an allergic reaction or contact dermatitis as well. Don't just note that a rash is present. You need to describe where it is, what it looks like, and how it is distributed. So start the head, ear, eyes, nose, and throat assessment with the head itself, looking for gross abnormalities like swelling, lumps, or deformities. Then we're going to move to the eyes, where you may be asked to do a thorough ocular exam. Vision changes, pupil size, and eye movement can all reveal neurological or systemic problems. Examine the eyes carefully. Look for the conjunctiva, for redness or swelling. Check for discharge or swelling as well, or jaundice. Shine a light to assess the pupils. Are they equal? Are they round and reactive to light? Are they pearl? Eye findings can point to problems ranging from infection to liver disease to neurological compromise. The ear exam starts at the outside. We're going to look for redness, swelling, or discharge, and then gently protract the auricle and use an orthoscope to look inside. You're checking for signs of infection, fluid, or perforated eardrums. Even mild ear findings can explain dizziness, balance issues, or hearing loss. When examining the nose, look for bleeding, discharge, or obstruction. Anterior inspections with an orthoscope allows you to see deeper into the nasal cavity. Pay attention to whether discharge is clear, cloudy, or bloody, as this can point towards allergy, infections, or trauma. Even something as simple as a chronic nasal congestion issue can have a big impact on sleeping and breathing. Finish the exam with the throat and the neck. Look into the oral cavity for redness, swelling, lesions, or dental problems. Check to see if the tonsils are present. Then move externally to the neck, feeling for swelling, lymph node enlargement, or tenderness. These findings often provide early clues for infections, airway compromise, or systemic illness as well. Our cardiorespiratory exam is one of the most important parts of any assessment. It combines all 4 techniques: inspection, palpation, percussion, and auscultation. Because the heart and the lungs are so closely connected, assessing them together gives you a complete picture of how well oxygen and blood are circulating. A systemic approach is very critical here. Always move in the same order so you don't overlook small details. Consistency helps you catch small changes like diminished lung sounds or a faint heart murmur that might otherwise go unnoticed. We're going to start with a posterior thorax like this. Look for deformities like scoliosis or kyphosis, asymmetry, scars, or rashes. As you palpate, check for tenderness and tactile phremitis. That's the vibration you feel when the patient speaks. Differences in phremitis between sides can suggest fluid, masses, or even collapsed lung tissue. Next, we're going to percuss the posterior chest, so you can tell a lot about what's inside by doing this. A healthy lung will produce a resonant, hollow sound. Dullness may point to fluid, like dullness like you're tapping on a wall and there's a stud behind it. That's the dullness I'm talking about. While hyperresonance can suggest air trapped. So like with emphysema or pneumothorax, it's a fast, non-invasive way to check our lung status. Listening to lung sounds is one of the most useful tools that we have. Pay close attention to normal breath sounds as well as abnormal ones. Wheezes, crackles, or diminished sounds. Also notice how well sound transmits. Muffled or absent sounds in any area may indicate fluid or collapse. Always compare side to spot these differences. On the anterior chest, start by locating the heart's point of maximal impulse, or their PMI. To find this, you're going to place your hand over the left side of the chest at the midclavicular line around the 5th intercostal space. We're feeling for this, and it can tell you if the heart is enlarged or displaced. Inspect the overall shape and movement of the chest as you go. Here's an example of that placement where you're placing your palm. We're going to palpate the pericardium, the front of the chest overlying the heart. You're feeling for thrills or abnormal vibrations that may suggest turbulent blood flow. These subtle findings can point to value problems or structural heart disease as well. When you start auscultating the heart, begin at the aortic arch. That is the 2nd intercostal space, just to the right of the sternum. Listen carefully for murmurs or irregular rhythms. Starting here gives you a baseline before you can move across to the other values. Next, move your stethoscope to the 2nd intercostal space on the left side of the sternum to listen to the pneumonic valve. Pay attention to the S2 sound here. You're listening for clarity, regularity, and any splitting or murmurs that may suggest valve disease. From there, slide down to Erb's point, located at the 3rd intercostal space of the left sternal border. This is an excellent spot for hearing murmurs that radiate or may overlap, because you can hear both aortic and pulmonic sounds here. If something sounds unclear when it's higher up, this is where we're going to double check. Then move to the tricuspid valve, located at the lower left sternal border around the 4th intercostal space. This is where you'll best hear issues with a tricuspid valve or right-sided heart problems. Listen for murmurs, extra beats, or irregular rhythms. Finally, place your stethoscope at the mitral area. This is near the 5th intercostal space along the midclavicular line. This is where you're going to hear the mitral valve the most clearly, as well as the apical pulse. Spend extra time here because it's often where subtle murmurs or rhythm disturbances reveal themselves. Do not forget the neck with this. Use your stethoscope to listen over the carotid arteries for bruits, those whooshing sounds that suggest turbulent blood flow. Our bruits could be an early warning sign of carotid stenosis, which increases the risk of stroke. Always listen before you palpate to avoid compressing a narrowed artery. Another important neck assessment is our jugular venous pressure, our JVP or JVD. So have the patient recline to about 30 to 45 degrees and observe the jugular vein. Elevated JVP or JVD can indicate right-sided heart failure, fluid overload, or even other circulatory problems. It's a simple bedside test that gives you a lot of information. Shifting to the abdomen, look for signs of ascites or fluid buildup. Gently percuss the abdomen. A dull sound may indicate fluid instead of gas or tissue. In some cases, you can even feel a fluid wave by tapping one side of the abdomen and feeling it on the other side. When patients have distended abdomens, we're going to measure their abdominal girth with a tape measure at the same spot for every visit. Tracking girth over time helps monitor fluid retention, particularly in patients with liver disease or heart failure. Even small changes can be significant. Check for edema by pressing on the skin over bony areas like the shin or the ankle. If the indention remains, that's called pitting edema. Grade it from a +1 to a +4 based on the depth and how long it lasts. Documenting edema is important because it reflects fluid balance as well as our cardiac function. Now let's move on to the neurological exam. We're going to start broadly looking at their mental status, speech and language, and cranial nerve function. These components together give you a good idea of how well the nervous system is functioning. Always take note of any sudden changes from the patient's baseline. Start with a gross assessment of vision. Ask the patient to read something nearby or identify objects across the room. You're not replacing a formal eye exam, but this quick check helps you spot vision loss that could affect safety, mobility, or overall quality of life. Next, assess the trigeminal nerve. That's the trigeminal nerve's motor component. Have the patient clench their teeth while you feel the masseter or their masseter's muscle. You're checking for strength as well as symmetry. Weakness on one side can indicate nerve damage or other neurological issues. Then test the trigeminal nerve's sensory component. Lightly touch the patient's forehead, cheek, and jaw on both sides, and ask if sensation feels the same. Differences in sensation can point to nerve impairment or central lesions. Evaluate the facial nerve by asking the patient to smile, frown, raise their eyebrows, or puff out their cheeks. Watch for symmetry. Drooping or weakness can be a sign of a stroke, Bell's palsy, or other issues. Have the patient say ah and watch the movement of the soft palate and the uvula. This test, it actually tests our cranial nerves 9 and 10. You're looking for symmetry. If the uvula pulls to one side or the palate doesn't rise evenly, it may indicate nerve damage. Ask the patient to then stick out their tongue. A healthy tongue should protrude straight and move freely from side to side. If it deviates to one side, it can signal that we have a hypoglossal nerve dysfunction. Now we're going to shift to motor tracts. So the cortical spine tracts carries signals that control voluntary muscle movement. Assessing strength in arms and legs or having the patient push and pull against resistance gives you that quick sense of how well this tract is functioning. Test sensory pathways like the spinothalamic and the posterior columns. Light touch, pain, vibrations, or proprioception can all be assisted at the bedside. Ask the patient to close their eyes and identify sensations to check accuracy. Unequal or absent response may help you localize neurological problems. Reflex testing sounds out the neurological exam. Deep tendon reflexes give quick feedback on both peripheral and central nervous system functions. They can also reflect electrolyte imbalances in certain cases. A brisk or an absent reflex can tell you a lot about what's happening as well. For the patellar reflex or the patellar reflex, have the patient sit with legs relaxed and strike just below the kneecap. The legs should extend slightly. For the biceps reflex, locate the tendon by palpation. So we're going to place your thumb over it and tap your thumb with a reflex hammer. The arm should slightly flex. Document whether the reflexes are normal, diminished, or even exaggerated. To check the brachial radius reflex, strike about 2 inches above the wrist while the patient's arm is relaxed. You're looking for a twitch or slight flexion at the elbow. It could be very, very small, but it still provides important information, and we do want to make this a part of our assessment. Abdominal assessment has its own sequence as well. Inspection first, then auscultation, followed by percussion, and finally palpation. This order matters. If you palpate too early, you can change bowel sounds or cause discomfort that interferes with the rest of the exam. Start by inspecting for scars, striations, bulges, or rashes, then move on to auscultation, listening to all 4 quadrants for bowel sounds. Are they active, hypo, or absent? Absent sounds for more than a few minutes may suggest obstruction or another serious issue. Percussion helps you tell the difference between gas, fluid, or solid tissues. A tympanic, drum-like sound usually means it's air or gas. A dull sound may suggest fluid like ascites or a solid mass. Don't forget to percuss over the costovertebral angle in the back. Tenderness there can point to a kidney problem, or aka the flank. Palpation comes last. Use light pressure first to detect tenderness or superficial masses. Then go deeper to feel organs and structures. Watch the patient's face closely. Sometimes the reaction tells you more than what you feel. Be gentle and explain what you're doing, since abdominal exams can feel a bit invasive on their own. You can also check for abdominal reflexes by lightly stroking the skin in each quadrant. Normally the muscle contracts towards the stimulus. An absent or uneven response may signal a neurological issue, though it's not always clinically significant though in every patient. The musculoskeletal exam helps you gauge disease progression or recovery after injury. Look at joint symmetry, range of motion, deformities, swelling, or redness. These observations tell you a lot about both function as well as inflammation. Have the patient move their joints actively or guide them passively if needs be. You can also use a galvanometer. I've never used one of these, but this is an example of what it looks like for those precise measurements. Compare both sides of the body to look for symmetry, since injuries or chronic conditions often affect one side more than they do the other. Inspect muscles and joints for symmetry and discoloration. Check flexion and extension of major joints like our knees and our elbows. Even small limitations or changes in color can point to major issues like vascular compromise or inflammatory arthritis. We are almost done, guys. So once the exam is complete, documentation is critical. CCP highly recommends the SOAP format for charting. That is the subjective, objective assessment plan. Keeps notes clear and organized. Subjective, remember, is what the patient tells you. Objective is what you observed. Assessment is your impression, and plan is what you recommend. Using a standard format makes it easier for other providers to follow your work. Last slide. So documentation isn't just paperwork, it is communication. Use standardized terms, avoid abbreviations that you could be misinterpreted, and write clearly so anyone reading your notes can follow what you found and what you did. Accurate documentation prevents mistakes and makes sure patient care is consistent from one provider to the next. Patient assessment is not a one-time event. It is an ongoing process that adapts to the patient's condition and setting. Whether you're gathering history, checking vitals, or reviewing systems, every detail adds to the bigger picture. The more thorough and consistent you are, the better your ability to recognize early changes and intervene before the problems escalate. In the end, assessment is the foundation of everything that we do. Treatments, referrals, and prevention strategies all flow from the information that we collect. When we do it well, our patients feel heard, and our providers have accurate data, and outcomes improve. As community paramedics, our role is different from traditional 911 response. We're not just racing against the clock to stabilize an emergency. Instead, we're stepping into people's homes, lives, and building trust, taking the time to truly understand their health picture. In Western North Carolina, this is especially important. Many patients live in rural areas where access to care is limited. Remember, they have issues with transportation, and chronic conditions often go unchecked. A careful, structured assessment allows us to bridge those gaps. By catching problems early, whether it's fluid buildup with heart condition, medication confusion, social issues, food insecurity, we are helping people keep healthier and reduce unnecessary hospital visits. That's why assessment matters. It's not just about gathering data, it's about seeing the whole person in the environment and working with them to prevent crisis. That is all I've got for you today. It's about 40 minutes of a video. Please make sure to answer the question at the end to get credit for watching this video. Stay safe, and as always, please hit me up if you have any questions, comments, concerns. Have a wonderful afternoon.